Thank you, Dr. Manish. Thank you for the introduction. Surabhi, I think you need to stop sharing so that I can share the screen. Thank you. So, over a period of the duration of last 1.5 hours, so we have gone through the molecular landscape of lung cancer. We have seen different targeted therapies, different targets, and now Venkat has taken us through the journey of osimertinib in advanced non-small cell lung cancer. So my job here is very limited data regarding the early stage lung cancer patient, but these are those important patients where if we treat early, so the outcome of the patient can improve to a larger extent. So we will discuss it's going to be a case-based discussion. I would like to call upon my panelists. So Dr. Venkat Pradeep Babu, you are here. So we and after that, Dr. Manish Sharma, you are also here.
Yes, I am here.
Okay. Dr. Abhishek Yadav. Dr. Abhishek, is he here?
So I saw he had joined. I think there must be some issue with his.
Yes, sir, he is here.
Dr.
Okay.
Rajat is there.
Dr. Rajat.
Yes, sir, I'm there. Dr. Abhishek is just coming back. He has gone with his dog for a walk.
Okay. Dr. Srijana.
Yeah, Dr. Srijana is here. Yes.
And Dr. Priyanshu.
Hi, sir, I'm here.
Hi. So
I think
now,
that after that IS couple has left, so Dr. Abhishek has occupied that Chagraj Stadium, I think.
so we have attendance of almost 100%. Abhishek is missing, but he will join in between. So let us.
Sir, I have joined. Am I audible?
Yeah, you are audible. So even if you are on a walk, then also you are audible on system. So here is my case. So it's a hypothetical case. This case doesn't belong to me or anybody else. So 67-year-old gentleman, non-smoker, presented with mild cough. Chest X-ray showed a very small lesion in the left upper lobe. CT chest showed lesion in the left apical lobe. So these are the CT scans and the PET CT scan of the patient. We can see here a lesion. So it looks like a solitary pulmonary nodule only. So the PET CT scan shows FDG avid lesion in the left upper lobe, and there was a pleural tag also, and this was the report. So intensely FDG avid, well-defined lobulated soft tissue nodular lesion in apico-posterior segment of left upper lobe with adjacent pleural tag. Non-FDG avid subcentimetric prevascular lymph node, likely non-specific reactive nodes, and we have come across these kind of reports where the lymph nodes, they are non-reactive. So we will discuss about it. So the biopsy from the primary lesion turns out to be adenocarcinoma of the lung. So now what next? So I think we will start with Abhishek only because he was the last to join. So Abhishek, what is going to be your workup? So we have discussed this on many occasions. So can you just elaborate on the workup?
Sir, sorry, there was a phone call in between, and I feel there's just a solitary pulmonary nodule, nothing else.
Yeah. So we have already done a PET CT scan. We have done a CT scan of the chest, and we have done the biopsy. So apart from that, do you need any further imaging test?
Till now, a CT chest has been done, nothing else.
CT chest, PET CT scan, even the biopsy has been done from the primary lesion.
Okay. And sir, what are the PET CT shows? There is nothing else except this thing.
No. There is a FDG avid left upper lobe lesion along with pleural tag, and the non-FDG avid subcentimetric prevascular lymph node is there, which seems to be non-specific.
What about the pleural thing? Sorry, I missed.
So there was a pleural tag along with the nodular lesion.
Okay,
So it's a contiguous one.
it's a contiguous one. Sir, I would like what has been the biopsy report?
Adenocarcinoma.
Adenocarcinoma.
So the question here is that do you do MRI of the brain in all the patients, or are there any patient where you leave MRI out of your imaging modalities?
So in this case, I would not like to go with the MRI brain.
And the reason for that? So it's a
practically-
loco-regional case. Abhishek, it's
Yes,
a
sir.
loco-regional case. In PET CT scan, we do not have any evidence of any metastatic disease, but yes, there is a lymph node which is less than 1 centimeter prevascular, which is in the draining area of
Less than 1 centimeter, non-FDG avid.
non-FDG avid.
Sir, I feel I will not go with an MRI brain in this case.
Okay, okay. Rajat.
Yes, sir. Yes, sir. I will go with MRI brain till the time it was being discussed. I've already got an MRI brain done.
So what is the size of the primary?
So it's 2.5, 2.6 centimeter. So T1 lesion.
T1C.
T1.
Okay. Well, the guidelines are basically for stage 2 onwards for MRI brain. But I think so for every curative setting, it's better to, do a MRI brain because, later on you can have some, down the line, if you have
I
a
would
brain
like to go for an
relapse.
MRI brain if the patient is symptomatic. Otherwise, I will not go for it.
So you are not wrong, Abhishek. So because the guideline says that if it is a less than 3 centimeter peripheral lesion, so then you can omit MRI brain because the chances of MRI brain metastasis is very less in this case. So, but the thing is that here is a lymph node which we are seeing, it has been reported as non-specific. So I do not know, because these kind of reports, they come to us on a daily basis, and which report you have to think that it is significant or non-significant. So it is something which is not clear till now. So Manish, what is your take on that? So will you take a T1 lesion with this
Okay.
non-specific lymph node as a significant one or non-significant one?
So see, with the T1 lesion which are solid less than 1 centimeter, the possibility of them throwing a lymph node in mediastinum if the PET scan is negative is extremely low, right? And if this is a solid lesion with PET negative mediastinum, the probability of having brain lesion is extremely low. We can skip that. But yes, for practical purposes, I am doing MRI brain in all my cases.
Okay, okay. So I think the consensus here is that yes, in a T1 lesion with a node negative status, few will be doing MRI brain, few will not be doing MRI brain. But like these days, with a medico legal such a strong intention of everyone to sue you, so I think MRI brain is something which I will be considering in all my patients who are going ahead with a loco-regional therapy. So another question is whether you are going to go ahead with the invasive mediastinal staging or not.
So peripheral lesion less than 3 centimeter, I think EVAS is not necessary and it can be done on table. But even in this case, I think there's a prevascular node. You cannot access that prevascular node with the help of EVAS. You need to have thoracoscopy to access that prevascular lymph node. But yes, 3 centimeter, less than 3 centimeter lymph tissue size, tumor size, peripheral bronchoscopy and mediastinoscopy, they can be done on table. You can skip that before doing surgery.
Okay, okay. So Venkat.
Yes, sir.
So what is going to be your approach in this? MRI brain,
MRI,
EBUS.
yes,
So
sir.
I think
MRI
these
brain,
are the two most important investigation, and we talk about these investigation day in and day out. And so probably you will be the best person after writing a book and after so that how should we proceed with that?
so the chapter on lung cancer was written by you only. So in that book, it is written that definitely in all the cases of NSCLC where it is more than stage 1B, we need to do the brain MRI. So because it is only one case that is going to cause a lot of headache, and when it is recommended, it is better to do. So in stage 1B, from 1B onwards, definitely MRI brain I will do, and invasive pulmonary mediastinal staging, yes, it is to be done before, because this patient, keeping in view of the performance status and the size of the lesion, looks like a surgical candidate, so it should be done.
So do you consider it as a peripheral lesion?
No, sir, it's a central lesion. In the CT scan, we can see it in the inner one third of the lung parenchyma. So looks like a
So
central lesion.
probably then this stage 1A, 1B guidelines for mediastinal staging, I think then it is gone. So we have to proceed with mediastinal staging in this patient, because it seems to be a central lesion.
Yeah.
So this we have already discussed. So here the NCCN guideline says in stage 1A you can directly like do PET-CT scan, and if it is a you can consider pathologic mediastinal lymph nodes evaluation, but it is not mandatory. So it is not recommended. But if you see in stage 1B onward, so it is definitely recommended, and pathological mediastinal lymph node evaluation, and you also should do brain MRI with contrast. So in this patient, US showed no enlarged mediastinal lymph nodes, medically fit, patient underwent surgery. So this was the histopathology report. Final staging was PT2N1. So which turns out to be stage 2. And the Priyanshu, so what do you think that that they have reported it as N1? So is it a adequate lymph nodal dissection which has been done for this patient? So we have a complete histopath report. So the margins are negatives.
Looks like an adequate, sir. They've sampled up to 11 stations, 11, 12, I think. So it looks like adequate.
Okay. So Venkat, can you
Metastatic
just throw some light on what is called an adequate lymph nodal dissection? And is it the adequate lymph nodal dissection?
So in lung cancer, at least 10 lymph nodes from the has to be present in the specimen after lobectomy, and it should cover reasonably both all the stations of the lymph nodes. So this looks like a reasonable lymph node dissection with covering from station 5 to station 11 and more than 12 lymph nodes. So yeah.
Okay, Abhishek. So so what is going to be your approach in this patient? So this patient is having a PT2N1 disease, adenocarcinoma. All margins, they are uninvolved. So adequate lymph node dissection has been done, and T2 was in view of visceral pleural invasion. So otherwise the tumor size was less than 3 centimeter. So what will be your approach?
Sir, adjuvant chemotherapy.
Okay. Are you going to do any molecular markers for this patient?
No, sir.
So adenocarcinoma, you are not a very big fan of ADORA.
Sir, T2N1, this I don't think we have a role of, we don't have to do any molecular marker till now.
Okay.
Till
So,
this nodal staging.
So Rajat.
if he has a recurrence, then if he has a recurrence after adjuvant, then I will go for a
Okay.
molecular marker testing.
Okay. Rajat,
Yes,
are
sir.
you
Yes.
here?
Yes, sir. Am
Manish?
I audible?
Yeah, Rajat, you are audible.
So I have already got EGFR done.
So you are very fast.
Yes, sir. Yes.
So you have support of
19.
Rajat sir, is it positive or negative?
It is Del 19. It cannot be negative in a AstraZeneca supported symposium.
No, it is negative only. Then we will ask about the positive scenario. So Rajat, so T2N1 and you have done EGFR testing, it has come out to be positive. Suppose if it is negative, so are you going to do any other testing also, like mentioned over here, ALK, PDL1, ROS, NTRK, BRAF? Are you going to do those testings also?
So I will do a PDL1 and I will do a EGFR. These are the two that I'm going to do. Yeah, as of now, these are the.
Okay, so why not others? So I understand that there are no trials suggestive of improvement in outcome with any other targeted therapy, but at one go, if you are going ahead with a molecular testing, so if you go along with the EGFR other molecular testing also, if it comes out to be negative at this point of time, so you know the results pre-handed at the time of progression, then you can start immediately with the whatever target has come positive, rather than again searching for the same.
Yes, I agree. But then, since there is no validation of other molecular tests as of now in a stage 2 disease, what I do in my practice is look for only EGFR and PDL1. This approach that you're saying can be one of the approaches, but then all this testing can be done later also once the patient becomes metastatic, if at all he does. And also in a stage 2 disease, I hope that I'm able to offer cure to the patient. So I'm not really looking at a metastatic disease straight away as of now.
Okay. So I asked this question to Dr. Aparna. So if you are doing molecular testing, so are you going to do it on the pre-surgical biopsy tissue or post-surgical resection tissue? And if there is some reason behind that, so what is that reason? So Manish, so you understood my question, na Manish?
इसको चुप कराओ.
Manish, are you here? Venkat?
So you are asking whether it's better to do the molecular testing
On
in the
the
biopsy or the
biopsy
resection
specimen
specimen.
or a resection specimen.
So it's same like ER, PR, HER2 testing. So once we know the results on the biopsy, there's no point in retesting. It will add to more confusion only. And anyway, we are doing on few cells. It's not like we are assessing the tumor heterogeneity. So once we are having the report on the biopsy block, there's no point in checking the resection specimen.
Okay, so I totally agree. So it's the amount of tumor.
Praveen, I want to ask you one thing. Sorry to interrupt. I want to ask you one thing.
Yeah, please.
In this case scenario, if it turns out to be EGFR positive, will it change the management post surgery? Yeah, it will change the management. So there is a ADORA trial, so which is of adjuvant osimertinib in stage 1B, 2, and 3 patients, where after the adequate treatment, the standard of care treatment, so these patients, they were tried against placebo and osimertinib. So 1:1 fashion, they were randomized into osimertinib and placebo, and there the disease-free survival is better with osimertinib adjuvant. So and the hazard ratio. OS data, sir, or not? No. The OS data is still not there, but the hazard ratio is very significant. So the hazard ratio is 0.12. Okay. So we will discuss about it. So I think now we have to move forward. So EGFR mutation positive. I think we will leave these questions. So Venkat, so what do you think that these days is there any role of post-operative radiotherapy in early stage resected non-small cell lung cancer? Maybe we can take it stage wise, stage 1 or 2, then stage 3. So stage 1 or 2, is there any role of post-operative radiotherapy?
So one of the most important indication, like in other cancers, is margin positivity, and the other indication is being I'm not sure, sir. I'm sure about the margin positivity.
Yeah, that's the only indication.
So for lymph nodal status, I think it is not an absolute indication nowadays. So if you had a result from lung R trial that clearly showed that if you have lymph node positivity, the post-op radiation is not going to benefit much to your patient. So only thing which have benefit, I think, is margin positivity and nothing else.
Okay.
In early stage, I think that's the only thing.
So I think the consensus is that stage 1 to no role of post-operative radiotherapy if there is complete resection of the tumor. R1, R2, yes, definitely we have to give radiotherapy. In stage 3, or if we talk about the nodal status, so nodal status N1 no role, N2 lung R trial has shown. So there is not much of role for adjuvant RT. But N3, if histopathology shows N3 or multi-station N2 with probably with EC lot of mediastinal burden, so which is exactly, it is not a scenario which we come across in our daily practice, because most of our patients, they are adequately staged pre-operatively, and the chances of getting such a huge burden of disease in mediastinum is very, very less. So role of SBRT in early stage NSCLC. So I think those patients where the comorbidities are there, so there we can consider. So what is your take on SBRT, Rajat? Priyanshu, so role of SBRT.
Sir, patient who cannot undergo surgery for any comorbidities, or who have a poor pulmonary function test, and who have expected FEV1 after resection is not satisfactory, and so in that patient SBRT can be given.
Okay, so this patient stage 2 adenocarcinoma, EGFR mutation, and as per Rajat, it was not DEL 19, it was L858 beta. So what should be the next approach? So I think we will start with Manish. So whether you will proceed with adjuvant chemotherapy, adjuvant osimertinib, or adjuvant chemotherapy followed by osimertinib. So what will be your approach?
So this is N1 disease, and I think we will proceed with chemotherapy followed by adjuvant osimertinib for this patient.
Okay, and for how long you will continue osimertinib here?
So at least till the time patient has toxicity, or 3 years.
Okay. See, the thing is, there are few questions which are still unanswered. So if we see the previous trials, so like Radiant, Evans, or CTONG trial, so there was a different trial schema which was considered in these trials. So there, erlotinib or gefitinib was tried against chemotherapy. So the chemotherapy was not received in the experimental arm. Here, so the benefit of osimertinib was seen in both the groups, whether the patient has received chemotherapy or no chemotherapy. So Priyanshu, so what is your take on in discordance of these trial results? So we have seen in CTONG, so yes, there was a DFS advantage and hazard ratio was 0.6 in CTONG trial, but later on it did not translate into the overall survival advantage. So is the fate going to be different for osimertinib? What do you think about it?
Sir, with the hazard ratio of 0.17, I think so I'm expecting a favorable OS profile also. And the second, as you already mentioned, was that the difference in the trial design also. And definitely osimertinib, we all know, is better with respect to CNS penetration also. And as we all know that in this trial also there were less of a loco-regional relapses, as well as better CNS control also. And we all know that CNS is one of the sanctuary side also. So I think so in the long run, this better efficacy and better CNS penetration would give us a favorable OS data also.
And what will be the status of chemotherapy in your patient? So will you go ahead with chemotherapy? See, we have seen the benefit of adjuvant osimertinib was there with or without chemotherapy. And the hazard ratio was almost quite similar. So 0.17 and 0.22, I think. So it was quite similar. So will you be considering, so one way of proceeding with it is that you can just tell the patient, we are saving you from chemotherapy and we proceed with osimertinib only, or the patient should continue with the standard of care treatment and after that only osimertinib should be started.
Sir, I would prefer to give 4 cycles of adjuvant chemotherapy provided he is platinum eligible and we can tolerate and PS is fine. Then I would like to give a we have 5% advantage according to this LACE meta-analysis. I don't want the patient to 5% is a big OS advantage, I would say. So I don't want the patient to miss on that.
Yes, so especially
until the data on OS is mature.
Especially in those patients who have node positivity. So the patient, they had 5-year overall survival advantage up to 10 to 15%.
Manish, node पे तो osimertinib भी काम करेगी ना?
Sorry, LACE meta-analysis. The later stage.
Sir, OS data अभी osimertinib का हमारे पास है नहीं, तो we are not very sure.
10 to 15% survival advantage है. So few of the patients, they are cured by chemotherapy.
अभी जो guidelines, what the guidelines say that you can even observe these patients.
The later stage.
So I think when we talk about any drug in the adjuvant setting, so you have to see the tolerability of these drugs also. And osimertinib, it has shown such a good tolerability that it is not exactly close to our hormonal therapy. But if we talk about chemotherapy and this, so it is very well tolerable as compared to chemotherapy. But this is exactly in the trial data. So we have seen in the metastatic setting, so there were some real world evidence also. So where the incidence of cardiac issues, so they were close to 8 to 9%. So I'm not sure whether, so I think we have to wait for the complete analysis of osimertinib, and we have to see not only the efficacy analysis, we also have to see the safety analysis of such a drug. And nobody is sure of whether it is delaying the reoccurrence or whether it is preventing the reoccurrence. So I'm not sure of it. So see, in CTONG trial, what we had seen was that the DFS advantage did not translate to overall survival advantage. But yes, the DFS hazard ratio was 0.6. So it was never such a less hazard ratio with erlotinib. So probably it is osimertinib which has to give the answer, and the maturity of data is something which we will have to wait for. So coming to, so these things we have already discussed. So this is the LACE analysis which showed the 5-year OS advantage of 5.4%, and this is according to the stage that the advantage was more with the stage 3 disease. And this was the ADAURA trial, and we can see over here that 2/3 of the patient, they were stage 2, 3A, which was in the primary endpoint analysis, and 1B stage was close to 1/3 of the patient. And here we can see the primary population, the hazard ratio was 0.17. And in the overall population, the hazard ratio was 0.2. So these were the previous trials. So the RADIANT DFS, again, the DFS advantage, initially it was there, but after stopping erlotinib, this advantage, this dipped down, and both the curves, they crossed each other. So if we see here, it is the ADAURA, so which shows that there is wide separation of the DFS Kaplan-Meier curves. So this is the CTONG DFS curve. So initially it's separated, then
1 second, please. So then later on they come near to each other after stopping the drug. So this is something which we have to see in the ADAURA also, so that the drug is being continued for 3 years. So we have to see after a follow-up period of 3 years that the curves are still separated. What is going to be the OS advantage with the drug? But yes, at the face of it, we have to take it very seriously. And osimertinib is definitely a contender as an adjuvant targeted therapy. So talking about the CNS involvement, as rightly pointed out by Priyanshu, the CNS reoccurrence was very less with the osimertinib in ADAURA trial. We can see only 1% of the patient who progressed in CNS vis-a-vis 10% with the placebo. So CNS is a sanctuary site. So coming to the final question, so is ADAURA practice changing? And I will take opinions from all of you. So we will start with Venkat. So is it going to change your practice? So now tomorrow, so you have a patient in your clinic who has underwent surgery and an EGFR mutated stage 2 patient. So will you give the patient post chemotherapy osimertinib for 3 years? Patient has finances, no issues regarding the finances.
So I will not use in all the patients, but those patients after explaining the chances of recurrence and who are really concerned about the recurrence, I will use it. Otherwise, I will save it for the metastatic setting.
Okay, so you are not convinced with the ADAURA data?
As of now, I cannot use in my patients.
No, but the patient has all the finances and it is FDA approved also. Venkat. Yeah. So patient can ask you that, is there any drug which you can give to prevent my reoccurrence?
Yeah, so I am mentioning the same, sir. So in those patients who is really concerned with the recurrences, because whenever I do explain the recurrence rate and all, even in the early and local advanced cancers. So in those patients who are really concerned, definitely I will use who have finances. Yes.
Okay, Manish.
My answer is yes. The data and the drug which is having such a good hazard ratios for PFS, I think we will have the overall survival as well. And please do remember that being progression free in CNS is extremely important, which has been shown in this ADAURA trial.
So Priyanshu.
Yes, sir, it's a practice changing. The only issue constraint being cost. So, but we are actually doing EGFR in early, NSCLC now, which we were not doing earlier. Although the subset of patient in my practice who are early stages, around 10% at the max. So the overall patient number is also less, but definitely it is practice changing.
Okay, Abhishek.
Sir, I have rarely seen a patient who has such early...
But you have a patient in your clinic tomorrow morning. So I'm sending you one patient who is post-resection setting.
I'll offer him, but then I seriously doubt.
No, but are you... So first of all, to convince a patient, you should be at least convinced. Yes, is it a practice-changing concept?
It is a practice-changing concept, sir. Definitely, even if it offers a DFS, then I'm okay with it. But then I seriously doubt whether it will give some OS or not.
Okay. Okay. Sir Rajat, final words from Rajat. So I think Rajat is not here.
Rajat is very busy.
He is always busy. So I think after seeing the results of ADAURA, yes, see all the trials, they have some criticism. So all the trials, they have some limitation. So but it was a very well conducted trial, and it has been done. So they have taken both the arms where the chemotherapy has been given or where the chemotherapy has not been given. So they were well justified with all these things. And even after that, if they are showing a hazard ratio of 0.17, so I think there was 83% reduction in risk of progression or death. So apart from that, if you see
the DFS at 2 years timeline. So it was almost doubling of the DFS. So 44% versus 90%. So this is huge. So if we see with the placebo, so the median DFS was close to 18 to 20 months. And at 2 years, if with osimertinib, so the patient is having disease free, almost 90% of the patient are disease free. I think in a later time. So this is very, very compelling. The data is compelling, and it will turn out to be having a overall survival advantage. And similarly, NCCN guidelines also recommend chemotherapy followed by osimertinib in those who are having EGFR mutated lung cancer early stage. With this, I would like to conclude the panel discussion. And I would like to express my vote of thanks to Dr. Manish Sharma and AstraZeneca for giving me this opportunity. If there are any questions, I think we can take up and we can discuss about it.
Thank you, Dr. Praveen. So it was extremely nice panel discussion.